Roland Joe guy. I think I've now decided I'm going to go with I'm the Froless Fro. I think I like that new tagline to bounce off Scott and piggyback off him. But I'm a sports medicine surgeon, knee, shoulder, elbow specialist. I love everything sports, and I'm very happy to be here today.
Thanks so much, Nima. And then last but not least, we have Mr. Harold Malbrin from Barnett Chase Farm Hospital. Thanks so much for joining us. Could you please give us a brief introduction?
Yes, thank you very much for the invitation. I'm Harold Malbrin. I'm a hip and knee surgeon from the Royal Field Barnett Chase Farm Limb. I had grown up learning to use the bone patellar bone in my training, and then I worked for a world-renowned surgeon who brought the hamstrings mainly to the United Kingdom, and ever since I've not really looked back. My main interests are in sports, particularly with ligament injuries, for example, ACL and meniscal tears. Very, very keen on meniscal preservation treatment, and also interested in orthobiologics. I'm present the postgraduate trust education lead for the Barnett part of the Royal Free Foundation Trust.
Awesome. Thank you so much, Mr. Nobuku. So with that, okay, would you mind discussing the article really briefly that we talked about, systematic review?
Thanks, no, with pleasure. I just want to apologize. I'm on call, so if I do drop out, Kartik will take over. This paper is titled Anterior Cruciate Ligament Reconstruction, a Systematic Review and Meta-Analysis of Outcomes for Quadriceps Tendon Autograft versus Bone Patellar Tendon Bone and Hamstring Tendon Autografts. It's a meta-analysis that was published in the American Journal of Sports Medicine in 2019 by Etienne Cavagnac's group in Toulouse, France. The aim of this meta-analysis was to compare outcomes of quad tendon autograft and on clinical studies compare quad tendon autograft versus bone patellar tendon bone and hamstring tendon autografts in ACL reconstructions, specifically looking at stability outcomes, functional outcomes, donor site pain, and graft survival. They hypothesized that the current literature supports the use of quad tendons as a strong autograft with good outcomes from using ACL reconstruction. The methodology was fairly standard and involved the search of several well-known databases, including PubMed, Medline, Cochrane, and Ovid, using the PRISMA guidelines. Primary text and review article references for cross-reference for additional articles that met the inclusion criteria. The keywords used in the search or quadriceps graft and anterior cruciate ligament reconstruction or ACL reconstruction with a search range of all articles up until May 1st, 2018. The included articles had one of three things. So firstly, a clinical study of ACL reconstructions using quad tendon autograft, whether that was a single or a double bundle reconstruction with or without bone block. Secondly, studies that compared quadriceps tendon versus bone patellar tendon bone grafts. And lastly, studies that compared quadriceps tendon grafts versus hamstring tendon grafts. They excluded clinical reviews, articles that were not available in English or French, studies with less than 12-month follow-up, and studies that investigated outcomes after reconstruction of other ligaments. But they did not mention the level of evidence of individual studies, and they did include revision surgery papers. Two authors performed the review of the papers independently, and conflicts were resolved before final analysis, but they didn't give any further detail on this process. The statistical analysis seemed reasonable to me. They did stability outcomes, including a mean side-to-side difference and percentage side-to-side difference, which was measured using an arthrometer, with a Lachman test of grade 0 or grade 0 or 1, and a pivot shift test of grade 0 or grade 0 or 1. In terms of functional outcomes, they looked at the mean LISOM score and the percentage of LISOM score greater than 84%, which is equivalent to a good or excellent outcome. And they also looked at the percentage of IKDC grade A or B, or mean IKDC subjective scores. And then they also compared the graft site pain and graft failure rates that I previously mentioned. They tabulated the results and then they calculated the mean standard deviations and they did a statistical analysis that was fairly standard for a meta-analysis of this type, including using forest plots and they also looked at funnel plot analysis, which showed that there was no small study effect size. They did use a Radham's effect model for any p-value less than 0.1 and again squared above 50%. So that perhaps is a point that we can talk about. In terms of the results, 324 articles were identified, 267 were evaluated after cuts between the databases were excluded. An additional 78 articles were included by screening titles and abstracts, but only 27 articles met the eligibility criteria, 15 of which reported on the ACLs treated by quadriceps tendon autograft alone. 7 reported the comparison between quadriceps autograft and bone patellar tendon bone autograft, and 5 compared the quadriceps tendon autograft versus the hamstring tendon autograft. And this meant a total of 2,856 patients were included. The paper then reports the outcomes, and for clarity, I would just take the absolute percentage. The actual figures, I'm sure you've all seen in the text. So in terms of the quadriceps tendon outcomes, a total of 2,166 quadriceps tendons were analyzed. Stability outcomes found that the mean weighted side-to-side difference in anterior tibial translation was 1.72 millimeters. 23.7% of cases had an anterior tibial translation greater than 3 millimeters. 81.2% had a Lachman's test grade of 0, and 96.1% had a Lachman test grade of 0 or 1. In terms of functional outcome, the mean lysosome score was 90.7, and in studies that reported the scores above 84, they found that that was the case in 87.9% of quads tendons. Objective IKDC grade A or B was found in 87.1%, and the weighted mean subjective IKDC was 83.1%. Donor site pain was found in 6.1% of cases, and graft failure rates was 2.1%. So this showed that it was a pretty good graft to be used. They compared the quads tendon to patellar tendon bone, and essentially found there was no statistical differences in any of the outcomes except for donor site pain, in which quadriceps tendon autografts were better. And in terms of the quads tendon versus hamstring tendon outcomes, there was no difference statistically between stability, IKDC scores, donor site pain, graft failure rates. But they did say that there was a statistically significant difference in the mean lysosome knee score in favor of the quadriceps autograft. But of note, one of the 4 studies was in the context of revision surgery, and 3 of the studies were of level 3 evidence. So the authors concluded that based on their findings, the quadriceps autograft is a satisfactory choice for ACL reconstruction and provides a stable and functional knee with a low morbidity rate. And they found that the quadriceps tendon autograft has significantly less Harvard side pain compared to BPTB and better functional outcomes compared to hamstring tendon grafts. That's a lot of information. Thanks, Tanner.
Thanks, Saqib. I know that was a lot to summarize. Sorry to put you on the spot there. That was a pretty detailed systematic review. But, like I said earlier, I think the key that I want is we have so many great panelists here with experience with different graphs, and rather than sort of spending too much time discussing the merits or the negatives of the paper, I really just like to hear from all of our panelists about the graphs that they use. And so the first real question that I had, I'm going to start with Nima, because I think he's maybe has to head out shortly, but I just wanted to ask all of you, my first question is, knowing full well that it seems like in the UK there's a little bit more preference for hamstring tendon, is what type of graft do you use and why? And going off of that, what are your indications for you to use different autografts? So if you typically use one majority of the time, what causes you to change from quad and use BTB, or what causes you to change from hamstring tendon for BTB? I'd love to start with Nima, and then just kind of work around the panelists if everyone's willing.
Hey, I appreciate that, Dinner. So for me, it's pretty simple. What I always do in all of orthopedics, and I hope it's the right approach, I think it's the right approach for me, is no matter what technique there is or what options of grafts or what different choices there are, I try to learn and do them all, because we have our data that we see through randomized control trials and retrospective studies, etc. And then we have our anecdotal data. And one of the big traps, even as surgeons and physicians, is we fall into the traps of anecdotal data. I see colleagues of mine who have had one ACL infection, and recognizing that's significantly less than 1%, they now are putting their grafts in Vanco. So I really try my hardest to avoid falling into the trap of anecdotal data. And to do that, I really work hard on being able to have every option available. So I do every single graft. I do most techniques. The only technique I don't do is transtibial drilling. And so for me, it really depends on the patient. It depends on the patient's activity level, their age, whether, obviously growth plates are open or not. What I basically do is I first split up between autograft and allograft. And if they're, college age or, older, like in their mid to late 20s even, I'm pretty much going autograft no matter what. Some early 30-year-olds, I still do autograft, but occasionally there's a early 30s who behave like they're 40, 45, and I lean towards allograft. But basically, if you're really 40 and under, it's autograft until proven otherwise. And the reason I do that is based on all the moon studies, which I personally feel are the best data we have available in the United States. Coming from Kaiser has great registry data. The registry data is mostly retrospective, and our moon, what those guys created with the moon studies, it's fantastic. It's the best data we have, and Keating showed that if you're under 25 and you do an allograft, you have a 4 to 5 times higher rate of failure compared to autograft. So I stick with the autograft in these high-level athletes and younger athletes. So then I decide, hey, well, which autograft am I going to do? If you have growth plates open, I'm going towards doing soft tissue. So I want to do hamstring or quad. Why I prefer quad, I trained hamstring and BTB in the last 5 years I've been doing quad. Why I prefer quad to hamstring now, and I'm doing less and less hamstrings, because the quad is more reliable in the thickness, the girth, obviously. It has more 800% more collagen. I find that it doesn't loosen as much as hamstring. Now that's anecdotal. Obviously, clinical studies show there's more. And then in the moon studies, we saw that there's several studies now that are showing that hamstring has a higher failure rate in this younger population. Now, if the growth plates are closed, I am BTB no matter what in that high school, college age range. And the reason for that is because if you see, again, the moon studies, under the age of 19, they have a significantly higher failure rate. And when we're talking about their failure rate being upwards of 10 to 15%, even at times, if you include both legs, as close as 20%, that's very concerning. What if you do a hamstring or a quad, and we don't have as much data on quads, where we see the tunnel widening, and I think quads, because they haven't been doing it as long, although RCR has been doing it since 1999. With hamstring, we see a lot of that data. We know it's not clinically significant, but there is one significance. It leads to a possible 2-step revision. And at that level of an athlete, at that age, I think that's scary. I don't want to put them through 2 surgeries. So I really, really want them to have closed bone tunnels and use BTB for me personally. I use quad as an option for where hamstring would be appropriate in the recreational athletes, people who are working like on their knees, plumbers, electricians, people who are working in construction, and they don't want the anterior knee pain or the risk of it. Yet they are still recreational athletes and want to have a good option for an ACL and use an autograft. So between those two, I think quad's thicker and it's more reliable. And I find anecdotally, when I do all 3, that quad is much closer to field to BTB for me than hamstring is as well. That's kind of like my breakdown. I still do hamstring for those who've had a hamstring on the other side, but I'm beginning to shift more and more away from it. Although I still want to do, I'm still doing at least 5 or 10 hamstrings a year. I do probably about 40 to 50 quads, and double that in BTB. That's a quick breakdown. Sorry, I don't want to take too much time, so I'm making this quick as I can.
Thanks so much, Nima. That was a great breakdown. Why don't we just go starting from the top, Mr. Gupta, you tell us, and then we'll go all of our faculty here. Thank you.
Thanks very much. I agree very much with Dr. Nima, and I mean the phrase that's been used in the past is a la carte surgery. I think you've got to really look at your patient, their demands, their activities, and their risk profile. My go-to at the moment is hamstrings, but I do probably about 15-20% patellar tendon. As I said, I have quite a pediatric population, and certainly at the moment I'm doing hamstrings. But the first I heard about quads was at an ESCA meeting, and I ended up having breakfast with a guy called Professor Hans Pacer, who's a French surgeon, and this was about probably, I think, 2008-9, and he said, "What are you doing?" I said, "Well, I learned on hamstrings." He said, "Why are you guys doing hamstring?" And I said, "Well, that's the thing that we learned on." He said, "No, you guys should be doing quads. You should be doing quads." So I started doing some quads, and I think there is definitely an advantage. I have some reservations about the sort of suspensory fixation of the quads, particularly on the femur. But my preference is for hamstrings. However, if the patient is hyperlax, if they are high-level athletes or footballers, I'll do a patellar tendon. If they want to kneel on the floor and pray, we have a lot of population who want to pray, I will definitely not do a patellar tendon, and then I will go for a quads tendon in that population. The only rider to what Dr. Nima said again is if there is a degree of hyperlaxity, I will add in an extra articular tenodesis. We did quite a lot of work at Imperial with that, with Andy Williams and our group. And I really believe in the lateral tenodesis in certain cases, certainly not for everyone. I think I'll stop there.
Excellent. Thanks so much, Mr. Gupta. Yeah, why don't I add that to the question, actually? I think it's a great thing to add. If you guys could mention if you're doing the extra-articular tenodesis along, or and what indications and how frequently, but we can move on to Mr. Bork.
Thanks, Daniel. Well, I agree broadly with what's been said. The only thing I disagree with from Nima is that I think anecdotal evidence is very important if you're high volume, because that's really the only time you will ever get a standardization of surgical technique and rehab. You're going to be putting your tunnels in the same place. You're going to be fixing the graft. The surgical time will be the same. The rehab will be the same. So if you follow your patients up, you will notice differences if you change your graft. And the problem, as we all know, and the problem in this paper is that the surgical technique and the rehab are going to be completely different for so many of these patients that it's very, very difficult to compare. And a lot of the research in ACL, it's the surgical technique that is not standardized that makes it very, very difficult to read into what is important in the data. But moving on from that, I trained, as I say, under Pincheski, who's done close to 12,000 ACLs, with a hamstring tendon. And one thing he taught me is that you get very, very good if you do the same operation again and again and again and again. And I think that one of the things I've been trying to do is I've been trying to get my surgery as reproducible as possible. And he said you need to do 500 visit. So as I approach, I'm getting towards 1,000 ACL reconstructions now. I know I've got quite good at hamstring ACL, and I think that the reproducibility, that's very, very important to the patient. And one of the things we discussed at the last Wexham Cruciate, those of you who were on it will know it was run as a webinar, is volume is very, very critical for us as surgeons. And if you are a la carting too much, then I could argue that you are not going to be as good if you're doing different surgical techniques than if you're doing the same every time. And that one extra rupture that occurs as a result of perhaps the graft choice, may be small fry in the potential extra ruptures by you being not as good as a surgeon as doing it many times one way. So mostly my technique is with the hamstring tendon, because I know that I have got good at that and I know what is likely to go wrong. But I certainly do applaud Nima in his approach towards the moon data. Is very, very important, and we had Chris Kading on the call back in November, and it is very clear that the young hyperlax patients are a problem. So certainly I'm really looking moving forwards towards changing some of my surgical techniques to use a different graft in these very high risk groups.
Excellent. Thanks so much, Mr. Bork. Mr. Saxena, can you give us your graft preference and your thoughts?
Oh, yes. I mean, essentially, I don't disagree with any of the speakers before me. I think ACL surgery, one of the things I trained under George Dow from the Royal Free Hospital, one of the things he said was that there's a lot of armchair orthopedics, and people talk about the kind of minutiae of orthopedics, and particularly with ACL surgery, there's that many techniques, that many grafts, that many sort of options. And I think we kid ourselves a little bit that one thing is definitely better than the other. And like the guys before me, I think you do kind of have to know a few different options, particularly if you do revision surgery. You certainly need to have options there. But predominantly I use hamstring, quadruple hamstrings. But I tend to use a flip cover technique to try and go anatomical. Therefore, you can get away sometimes with just a triple semi-T, or even just need to take one hamstring. But I always supplement it with a secondary fixation using a fiber tape technique and that swivel lock anchor. I tend to use the sort of sling technique on the femoral side and a bi-composite screw on the tibial side. And as I say, I'll tend to always use the secondary fixation. I do a small amount of BTB, and I think, again, some people do ask for it. There are certain patients who, if they're a particular, for example, sprint athlete or certain patient choice, then I have no issues. But again, I'll use a tightrope technique with the BTB. I've also used allograft in patients where either there's a lot of concern about sort of donor mobility or in a revision scenario. So that's essentially what I do in a nutshell.
Excellent. Thank you so much for that. I just want to introduce another one of our speakers, Dr. Vonda Wright, who's a sports medicine orthopedic surgeon in Atlanta, Georgia. And, I just want her to, if you could give us a brief introduction, that would be great. Thanks so much for joining us, and we look forward to hearing your perspective.
Hi, thank you so much for having me on. I apologize. I had a little bit of trouble with the tech, but I'm here now. So my brief introduction is I served my residency at the University of Pittsburgh. I served my fellowship at the Hospital for Special Surgery in New York, which is where I still do a lot of what I learned there in terms of the ACL. And then I was faculty for 16 years at the University of Pittsburgh. Took care of the University of Pittsburgh football team as their lead doc, and then the Olympic sports teams. And then 3 years ago, left that place to come to Atlanta to build an orthopedic surgery department, which we've done with about 25 surgeons and all subspecialties. So I do everything sports that you can imagine. About 40% of my practice is hip arthroscopy, and the rest is shoulder and knee. So that's my intro, and I'm happy to add my opinions or just listen to the rest of the experts.
Excellent. Thank you so much, Dr. Wright. Yeah, actually, right now, just to reset the room briefly, everybody, we're going through our expert panelists, and they're discussing their ACL graft preferences and why they use a certain graft in a certain situation. And some have sort of included some of their fixation techniques, but that's something that I was going to kind of go through shortly as well through each of our panelists. But next we have Dr. Stegman, if you can talk a little bit about your graft preferences and when you use one graft over another, and whether you're doing the extra-articular tenodesis as well.
Okay, thanks, Gennaro. My pleasure. So I've been in clinical practice for 25 years. Started using the BTD, then moved to hamstring, and then 5 years ago moved to quad tendon as my primary autograft choice at this point. I'm a big believer, as most of the panelists have stated at this point, is really making sure that you're adept at multiple techniques and being able to tailor the choice of the graft to the individual patient. So for my patients that are age or older, I will typically lean towards an allograft unless they specifically want an autograft. And then as a team doctor for Division I college and taking care of a lot of younger athletes as well, I've switched to the autograft tendon, which is basically the quad tendon. I do an all-inside soft tissue quad tendon graft. There's a number of reasons why I've moved into this. Specifically, there's more collagen associated with the quad tendon compared to the BTB. And again, zero graft anxiety, and it's a very highly reproducible graft when you're going to procure it. You get great visualization. You don't have to worry about turning corners or taking a hamstring too soon, although the experts on this panel, I'm sure, are 100% with their hamstring grafts. There was a recent study out of Japan looking at MRI imaging of quad tendon ACLs, and they demonstrated that the grafts were actually incorporated at 6 weeks, which is a lot of the concern that many doctors have as far as the suspensory fixation. I use the tightrope from Arthrex. That potentially could loosen over time, but the tunnel is filled with this collagen, and again, good studies are or biologic fixation. I am not a big fan of BTB tendons for my female soccer, lacrosse, as well as field hockey athletes. Way too much patellofemoral pain associated. Many of them are under 5'5", and so I am scared and respect the patella, and I use an all-inside quad tendon for my female athletes, especially that are high energy pivoting athletes. And I do not do an extra-articular procedure.
That was a really great summary, Dr. Thank you so much for that. Mr. Naobuku, would you give us a brief sort of description of your preferences and kind of your technique as well?
Yeah, I started the journey on ACL reconstructions using bone patella bone, and I quite enjoyed it. But when I then moved to on my rotation to another hospital, inspired by a surgeon well known by many of the knee surgeons in the United Kingdom and abroad. And he was one who was the champion for hamstring ACL reconstruction and a Macintosh procedure for most, if not all, of his patients. The problem was that with the Macintosh procedure, some of the patients were not too pleased with the size of the actual incision. And then when I became consultant, bone to bone, and that was really in response to when the patient requested a bone to bone. But the majority now, probably nearly 99% of the time, I use autografts. And I'll even use autografts in patients over 50. I have anecdotal examples of Zumba instructors who've had autografts and have actually recovered very, very well and they've not failed. There are instances where I would use what you read and the meetings you go to, using the ALL, the anterolateral ligament reconstruction in some patients who have a pivot at the end of the operation. I'll also use it in the case of revisions. But generally speaking, I've been very pleased with the hamstrings. At times I will use 5-8 just really to make me feel a bit more comfortable. I use suspensory fixation using the retro button from Arthrex, and I use a bicomposite screw for the tibia. I tend to go by the what we describe as the transportable technique rather than transtibial, although some of the articles in the last few years indicate that the transtibial approach is actually becoming more and more popular and there's less failure when compared with the transportable. I suppose I'm not so much more comfortable using the transportable technique that I've continued till today. That's me.
Thanks so much, Mr. Albuquerque. That was a great review. Yeah, actually, it's a great topic you bring up. It's going to be my next question for any analyst. Once we finish with Mr. Miller and Dr. Wright about what portals are you using, and are you using a transtibial technique or using accessory medial portal? But with that, if we can just hear from Mr. Miller and hear what his graft preference is and how he's come.
Thank you. So my practice, I use a mixture of hamstrings or patella tendon graft. It seems that we've been on for 15 years now, and in my early practice, I was using the majority of hamstrings and just a small number of patella tendon grafts, particularly for hypermobile patients, more elderly patients with a medial collateral ligament injury, where I didn't want to stay the medial side of the knee. I like the patella tendon graft, old patients where I get the bone healing within femoral and medial tunnels, and of course revision surgery where patients already get their hamstring harvested and they have a revision procedure, and I'd use patella tendon for that. I've in a bigger change towards using slightly more patella tendon grafts over the last 4 or 5 years. I think that's possibly a swing maybe in the UK that slightly more people using patella tendon grafts. Other point is specifically for the hamstrings graft, the young squat muscular males, I'm sure the panel would be, you tend to find you get quite a short graft length in your harvest for these people. So sometimes that's the real. But overall, I use probably about 75% hamstring graft and about 25% patella tendon graft. I think the main issues that I look for are, I want to make sure that we have a good chunk of graft incorporation within the tunnels. So I prefer to have a good length of graft within a tunnel. And also, if I'm using hamstring graft, we know quite well that grafts that are less than about 8 millimeters diameter are more likely to fail. I don't really want to put in a accessory material through the knee next to a thin graft to avoid it from failing. I'd rather have a larger diameter graft. So I'll use hamstrings and make a 5 or 6 tendon, a 6-strand graft if necessary to achieve an acceptable volume of graft tissue when I'm doing the reconstruction. And more recently, I have been looking at using anthrax as part of primary surgery, especially the more a very big shift preoperatively, and I take a great care and attention to make sure I'm not missing a posterolateral corner injury with some of these people. So some patients will have an ACL plus posterolateral corner reconstruction if they have true, if their dial test is increased. But some patients just have a large pivot without a posterolateral corner injury, and I'll be considering doing anterolateral at the same time as their hamstring. Obviously, then the decision depends on what graft goes into which. I might use a patellar tendon graft for the ACL plus a gracilis for the anterolateral ligament. But yeah, that's my sort of thinking generally. Thanks.
No, thank you. That was a wonderful summary. Dr. Wright, really excited to hear what your thoughts are and what your graft preferences and how it's evolved over your career.
Thank you for letting me talk to you about this. So when I first got out of fellowship, we were still doing transtibial. We were, and it's just been such an amazing thing to watch over the years. So today, I'll just tell you what I do today. Today, I use mostly BTB autografts in young, healthy athletes, whether they're men or women, and I'll tell you why that is. Anybody going to the NFL or pro leagues where they're graded in combines get a BTB from me. I know there has been a shift in some of the higher level athletes to quad tendon, and I will do that. In two instances, number one, if I'm asked for it, or three instances, I'm asked for it, they've had a quad on the other side by somebody else, or their patellar tendon quality on MRI is not great because these are longtime athletes and sometimes they've had patellar tendonitis, and I'm not going to put that in transtibially, but now with respect to the natural anatomy of the ACL and wanting to come far down the wall, I do through the medial portal, and it works really well. Unless the ACL is ruptured off the femur, in which case I cannot do this. If it's mid-substance or off the tibia, I will leave a little, as I'm debriding the notch, I will leave a little piece of the native ACL so that I am replacing the anatomy with it near exact to their original anatomy as I can. When I was training, we would just denude the whole bone of the notch, and then you're left guessing what clock face you put the graft back in. But if we're going to recreate the natural anatomy, which is what we're charged to do, Dr. Houston used to talk about that a lot, I leave a little piece. Through the medial portal, BTB, unless I'm asked for a quad, or whether I'm asked for a hamstring. I don't use a lot of hamstrings even in young women, especially in young women, because I find that even with the quadruple graft, I'm still sometimes looking at a 7-8 millimeter piece of collagen, and it just doesn't make me feel good at the end of the day. And maybe I've been really, really lucky. I have not had a lot of anterior knee pain in my people over the years when I use a BTB. So that's by and large what I use. I'm always mindful when I'm measuring the graft. In my experience, the intra-articular distance is usually about 30 millimeters. So if you get a BTB tendon out and it's a 40 or 50 millimeter distance between the bone tube, and plan ahead for that with your fixation. And then finally, I do use allograft. I use allograft in lower output master's age people. So the definition of masters keeps getting older and older as I get older. But, people in their late 40s, 50s who aren't still high-level athletes. They're recreational people. And my allograft of choice is the Achilles tendon because I put the bone plug in the femur, and then I have the option of soft tissue in the tibia, and it's just a big, solid piece of collagen that I've been really, really happy with over the years. And I am really interested in some of the other faculty's thoughts on quad tendon atrophy. Just to admit to you, despite coming from Pitt, I have not pivoted to the patellar tendon exclusively because, you know, the poor quad atrophies anyway. And I did the original 30-year follow-up on Russ Warren and Tom Wickowitz's ACLs from HSS way back in the day, in the 80s when they started. And even though the strength gets back with the quads, sometimes the volume never gets back. So that's just made me hesitant. And I'd love to hear the other faculty's experience with getting their quads back.
I think that's a wonderful question, Dr. Wright. I'd love to open it out to the rest of the faculty. Really briefly, I'll have Dr. Bergenthal just introduce himself, and you know, I'm sure you have some contributions. Thanks for coming on stage, and then we'll get to the faculty to talk about quad atrophy after quad tendon ACL.
Okay, yeah, thank you very much. I mean, many things are said. I'm originally from Germany. I'm working as an orthopedic surgeon there, and I've done also semitendinosus. I've done BTPs, and now also switch over a little bit to quad tendons. From my point of view, I think that for the second ACL repair, I use the BTBs more than any other at the moment, because I think that the patients do very good when you use the patella tendon bone as a transplant, and I have a very good experience with that. And I think maybe one interesting question would be the diameter of the transplant. I just read articles from Australia, and they did a big review, and the major risk of re-rupture was age, and the diameter was not the major risk factor of re-rupture. Maybe that's one issue that we can also discuss in the audience or in this high faculty. And I'm also interested in ALL. I've started doing ALL ligament reconstruction. I think that maybe the numbers of re-ruptures going down also with this second procedure in the knee. So that's would be my points in this discussion. Thank you very much.
Thank you so much for coming on stage and your contribution. So yeah, I guess we could open up to the panelists, Dr. Wright's question about quad atrophy, and then we can go from there. I'd love to hear from everybody.
Dinner, do you mind if I make a comment before we get into the quad atrophy?
Oh, absolutely. Go ahead, Nima. Thanks.
Cool. I actually agree with pretty much with a lot of the comments all the panelists have been saying, even though there's some differences. One of the things that we need to recognize is we have a little bit of a regional difference. And Dr. Wright and I have a lot of similarities, I think, in our thought process. Also, obviously, Dr. Sigmund. But one of the things that Kurt Spiller gave a talk about 7 or 8 years ago, and he was talking about how at the Division I level, we were finding that some athletes were actually, their scholarships were being affected because of graft choice. And whether that's right or wrong, I don't have it. I actually truly believe that whatever the surgeon is best at in your local community, and they can have the most reproducible results if they're using an autograft on a young athlete. We're getting to split hairs a little bit. You know, I have the same preferences as Dr. Wright, but and it's similar to Dr. Sigmund, but it's something that we need to encourage people. I always tell people who will message me from Oklahoma or around the country, I say, hey, if the person there is using a hamstring and they've been doing this for 10 years and they're reproducible, you know, you go do what that surgeon in your community can do and do well. Obviously, tunnel position, autograft choice, that's wonderful. But we do have a little bit of a regional bias. And according to what Spindler said, I found that there's actually some truth to it. And we found that both at the college level, I'm sure Dr. Sigmund will have some comments. I don't know if it's the same for him and his experience, but at the college level and at the pro level, we're seeing a little bit of a bias. I see Marco Nunez was on the, he's down below. He's the head athletic trainer for the Lakers. When I used to work with Marco, this came up a lot. And when athletes start coming into the combines and they have hamstrings, it was becoming a problem for some of the surgeons. Whether that bias is correct or not, it affects our community in the United States. And there's a bias in the other direction from what I think across the pond. Maybe incorrect about that. But the reason that comes up, or when that bias comes up, it's something that we have to take into account because we want to make sure our athletes have the best opportunity. And I agree with Dr. Wright also on the knee pain. There's a recent study that came out that said after 2 years, our anterior knee pain is dropping. The massive systematic study below 3 to 5%. So just things to think about. I think we should always be very gracious toward each other's thoughts and opinions because, again, at the end of the day, we have a lot of real great surgeons all over the world who are doing the best by their athletes. One of the reasons that I went away, even though I trained mostly with hamstring and went away from it, was because, kind of to Dr. Wright's point, even on these female athletes, their hamstrings tend to be weaker than their quads. We see that they're very quad dominant. Hamstrings are the dynamic stabilizer of the ACL, the secondary stabilizer. So I started becoming a little bit more nervous. Even though I've done 500 plus hamstrings, I still started to trend that down a little bit. And that was my thought process. But I appreciate you all. Soon enough, I'm going to have to go pour my daughter some tea for her birthday because we're having a tea party. But I'll try to stick around for a few more minutes. I'd love to hear your thoughts.
Okay, can I come in? It's Jim Gupta here.
Please do. I think, at this point, we can just really make this more of a free-form discussion. We're thankful to have so many great panelists here. So we'd love to just hear everyone's opinion and sort of form a free-flowing discussion.
That's brilliant. So if I could just address a couple of things, particularly the BTB versus hamstring debate. I think we all agree that the first thing you choose is your surgeon, not your graft. And clearly, people who are familiar with a particular technique are probably better at that technique than the other. I think really, if you're kind of specializing in knees and sports knees, you've got to have at least 2 or 3 graft choices for the reasons that have been alluded to. When I look at my BTBs, I do find that their endpoints are slightly firmer than the hamstrings. I too can I triple my hamstring, so I can get a 6-strand hamstring graft. The only issue I have with the 6-strand hamstring graft is that there's quite a lot of suture in and around the graft, and I just wonder whether that changes the vascularization of the graft and whether that graft matures as quickly as a BTB that's incorporating into bone. So I use BTB for elite level athletes. I do think anterior knee pain is an issue in that first 18 months, and they find it difficult to get their extension back a little bit because of the anterior knee pain, not because of notch impingement. So that's why I don't use BTB as the go-to in most of the weekend warriors. If I could just address the ALL question, because we did quite a lot of that work back in 2011, 12, 13, Imperial. I think the pendulum swung one way and the other. So Macintosh obviously came in the 1970s and 80s, and it was a huge, quite brutal operation, but it worked really well to control privet. And then it all fell out of fashion when arthroscopic ACL surgery came in. And then quite a lot of groups were doing this work because they were looking at Sagon fracture and trying to understand the nature of the Sagon. And what we found was there was we call it the ALL. Having dissected out 50, 100 knees, it's a condensation of tissue. It's a bit like the posterolateral corner. What is the posterolateral corner? What's the arcuate ligament? There is a condensation of tissue that helps control pivot. I'm not sure it's always distinct as an ALL, but you've got to think about addressing that extra-articular lateral side. And the way I do it is with taking the ITB, keeping it attached just posterior to Gerdes, which is not far off what we found as the ALL insertion. And you've got to take it deep to the lateral collateral ligament and attach it proximal and posterior to the lateral epicondyle, because that is what gives you the extension control and pivot. So I don't use the hamstring tendons for a lateral tenodesis. I think that the ITB does very well. There's some debate as to how you fix the ITB. I fix it with an anchor, and I use it in 3 conditions: hyperlax, grade 3 pivot, and a revision where someone probably with a great pivot. Related anterior knee pain as well, so it's not without its morbidity. Gives you great pivot control, and I use it particularly for my hyperlax pediatric population where I use a transtibial technique with a slightly more vertical femoral tunnel to avoid damage to the physis, particularly in the young adolescents, the 11, 12, 13-year-olds. So it gives me great pivot control when I need it. And again, it's a skill that I think is worth having.
Thanks, Mr. Gilby. I'm going to have Dr. Sigmund up, and I think he had a couple comments, and then we're going to have Marco give us his perspective as a former head athletic trainer for a very well-known professional sports team in the U.S. on draft choice.
All right, sorry, thank you. It's funny, I just want to answer a little bit about the quad because it seems like I'm probably the one doing it the most on the call. It's interesting. I don't take care of Division I football athletes at our college, so I'm not a part of that, but we do have an outstanding hockey program. And so in hockey, ice hockey, we don't see nearly as many ACL injuries as we do in other sports, but it does occur. And it'll be interesting to get Marco's perspective on this, but a lot of the decision making is actually agent driven at this point. The kids that are already drafted into the NHL or are in a position where they're going to be high up in the combine, have agents early on, and they really help to self-direct the type of care, as well as what graft choice, as well as what surgeon is going to be well. From my school, one of the theories that over the BTB, as far as patellofemoral pain, is that you can imagine if you take the BTB, you could potentially get some infrapatellar scarring, which increases patellofemoral contact force, which could then translate into increased pain. If you're using the quad tendon, if you're going to get anything, it's going to be pulled north, which will reduce, potential patellofemoral contact force. So that's my thoughts.
Thanks, Dr. Sigmund. Before we jump over to Marco, I just want to do a quick reset on the room. For those of you guys in the audience, thank you guys so much for joining us. This is the Bone Club. We're doing our Sunday Journal Club. Today we're focusing on ACL reconstruction, and we've had a variety of really excellent comments about whether BTB, some of the complications of those grafts, whether we're going to use a intralateral ligament. We're going to do an intralateral ligament repair as well, based on the pivot shift at the end of the case, and then fixation techniques as well, which I would like to get into before we finish up today. But again, thank you guys so much for being here, and I'm going to have Marco jump in, just give us a really brief perspective from being a head athletic trainer and a physical therapist, and sort of knowing professional athletes really well after ACL reconstruction. Marco, you want to jump in?
Hey, Doc, how are you doing? Thank you very much. Thank you for having me here. My name is Mark Nunez. I'm a performance athletic trainer. I've spent the last 22 years working primarily with professional teams. Most recently, I was a head athletic trainer with the Los Angeles Lakers of the NBA. I had the opportunity to work in the patella. I spent the majority of my time working in the sport of basketball, which involves a lot of plyometrics and jumping explosiveness. As we all know, the hamstrings and the glutes and the calves as part of the posterior kinetic chain, the ones that kind of are involved in that in those movements. Now, also, like Dr. Nima had mentioned, as far as with females, then being more quad dominant versus hamstring. Hamstring is one of the biggest issues that we try to kind of focus on with female athletes, try to kind of reduce the incidence or occurrence of ACL injuries. So when it comes with athletes, oftentimes a lot of professional athletes try to kind of go more with the patella, because as we are rehabbing or prehabbing them, so to speak, even before their injury, we're focusing on strengthening the hamstring muscles to try to kind of reduce that. And
Hey, Marco, I think we might have lost you. I don't know if anyone else can still hear him. But
No, I think he's off at the moment. Perhaps we can come back to him in a moment.
Marco, we'll hop back on with you. I do want to jump to something shortly here. Actually, the next question that I had for all of our panelists, which was going to be, just your technique surgically when you're performing your ACL reconstruction. And of course, this varies based on the graft that you've harvested, VTB, quad, hamstring, soft tissue with a bone plug. But I would like anyone, whoever feels like they want to chime in, to talk about what portals are you drilling through? Are you using an accessory medial portal? Are you doing a transtibial technique? And then, what kind of fixation are you using? Obviously, this depends on whether you have a soft tissue graft on the femoral side. You're using skin or using
So for an adult, I use a transmedial technique. I don't use an accessory medial portal, but I often look through the medial portal once I've done just a mark with a chondral pick. So I mark my tunnel position, and if I'm worried or I'm concerned, I will check through the medial portal before I drill. And on the femur, I use the suspensory with or without aperture fixation as a supplementary, depending on the size of the tunnel and what I think about the patient, whether they're hyperlax or not. I do worry slightly about the suspensory fixation on its own in the femur, particularly if someone's hyperlaxed with hamstrings. Because I think that there's a little degree of stretch, there's a longer working length of the tendon. So I then put in maybe a downsized screw. On the tibia, I use metal because I've looked at the Danish registry, and there's quite a few studies that show that the bioabsorbables have a higher re-rupture rate, and it's not clear why that is. And I just worry about that. So I just use metal on the tibia. And I think there's quite a great push from the companies because it's more profitable for them to do to push for the PEEK or the bioabsorbables. But I find the metal's just as good. Transtibial, as I said, just for the pediatric population, and that's my fixation. For BTB, I use a soft screw by Smith and Nephew.
Thanks so much, Mr. Gupta. I think Nima's jumping off. I don't know if you want to just give us a really brief summary of your technique, Nima, before you have to head out. Thanks so much for joining us. Appreciate your time.
I was literally about to. Yeah, no problem. I'll talk about the quad because I think that was the main reason for me to be on here. And I'm like Dr. Sigmund, I do about anywhere between 40 or 50 quads a year. To go back real quick to answer Dr. Lay's question, yes, in terms of quad atrophy, I do see some, but like Dr. Sigmund said, it's not that bad. There's some similarities to BTB. Dr. Okaroha and I, over at the Mayo Clinic, are doing a randomized control trial right now comparing BTB and quad atrophy on isometric strength. So we'll have that out. There's some data that says that at 3 years, that over 90% of the quad is returned. But yeah, it does take a while actually in isometric testing. Now, in terms of fixation, so I do the tightrope just like Dr. Sigmund. All soft tissue quad. For me, the quad really is replacing the hamstring for recreational athletes. I'm doing less hamstring, more quad. Fixation on the femoral side is with the button, the tightrope from Arthrex, and I triple loop that through the tissue, so there's no give. And then on the tibial side, I used to do what was similar to like a post and screw washer. The person who taught me the quad was one of Arciero's original Arciero's fellows, and he uses this screw and washer technique. I started with that, but I didn't like the excess metal, so I switched over to doing a screw, a biocomposite screw, and I backed it up now with a swivel lock in the TV and show the difference between the flip cutter. The angle that you're a bit different, and I find the flip cutter is by far the most reliable in my hands, at least for an anatomic portal. But my anterior medial comes close, as good as I think I can get it, and I use screws for BTB on both sides. I do metal in the femur, composite in the tibia.
Thanks so much, Nima. I'll go ahead and just open the question back up to everybody else. Any of the other panelists who want to jump in. Thank you.
Yeah, I'm happy to let you know about my technique. I think I alluded to it earlier. Again, I use the flip cutter 3, which allows you to, particularly if you're doing all inside technique, you can drill tibial tunnels of different diameters. Particularly, it's always a little bit thicker because of the whip stitch on the tibial side. It allows me to go completely anatomical. I feel I'm not constrained by any of the portals, and it's really useful in a revision scenario where you can often do it as a single stage procedure because it allows you to use the same femoral portal or femoral tunnel entrance, but come out somewhere different on the femur to avoid that issue with tunnel merger. I prefer the tightrope, and it just allows me to, once you've tensioned everything, you can go back and retension on the femoral side if you need to, if there's any give. But I always back it up with a secondary fixation with a fiber tape, running through and held with a swivel lock anchor. On the tibial side, I tend to use a fast thread screw, so it's a biocomposite screw that has little holes in it to allow bone to grow into it. But for the swivel lock, I try to use PEEK just because often in younger patients, hard bone, the biocomposites, small biocomposite screws can often cut through, and the PEEK just allows a bit more of a firmer grip. Thank you.
Excellent. Anyone else want to jump in?
Hello?
Hey, what's up, Mark? You back?
How you doing? Yeah, I'm back. I apologize for that. Just real quick to summarize, as far as being hamstring, working in a plyometric sports where, like I was mentioning, hamstrings are the primary plyometric.
Hey, Mark, I think you muted yourself.
So maybe I can tell you what I use for fixation. Also the tight ropes, and not only femoral side, also tibial side. I use a tight rope for fixation, and I use the bio screws in case of revisions or PTPs. And I think, and I do the lateral portal to use the lateral portal to put the anatomic the heart rate system works really nice, and especially I think I can use this fixation method for every transplant that I can use. I use it for the quad tendon. I use it for PTP also, and I use it for the quad tendon if I need it. So I mainly individualize the surgery for the patients. That's my fixation system.
Here. Well, my evolution started with this passion for apparative fixation, and that was something we certainly knew about at the Wexham Park ACL meeting. So I started with screws for the femur and the tibia, and then of course you get influenced by some of your colleagues. I then went for suspensory fixation using the Francis pin, but a number of patients complain of a lateral knee pain, and that's partly because of the prominence of the pin. Then I went on to using the bioabsorbable pin, but after a while we encountered a few cases where the transverse wire snapped. So I went back and reviewed the cases I had and realized perhaps I should try another method. And that was when I came across the endo button and then went on to the tightrope. And I've used that since, and that's probably more than 12 years now. For the tibia, I used to use a screw and a staple because what was I grew up on, and then I stopped using the staple and I used the biocomposite screw. On occasion, I will use a swivel lock if I'm concerned about how good the fixation is in the tibia. And so far, so good. So I've been very pleased with using the suspensory fixation with the retro button and the screw fixation using the biocomposite screw or PEEK screw for the tibia. And that's me.
I am an aim portal guy using tightrope on both sides. And what I like about the tightrope, especially with the quad, unlike the hamstring, you're not going to get any creep in the quad tendon like you might for the graft preparation for the hamstring. So I've got to roll, but I want to give a big shout out to who's going to be on the Ortho Show this week. We're really excited to have him on as a guest. And if I'm not mistaken, I see Professor Levine maybe in the audience. I think we ought to bring him up and give a little shout out as well.
Yeah, I just invited him up, but I just wanted to introduce everyone. Dr. Lane Levine, who's in the audience, is an incredible leader in orthopedics and the chairman of orthopedics at Columbia University, and I'm glad he's in our room listening in on our discussion on ACL reconstructions. Thank you, Dr. Sigmund. Appreciate it. Dr. Wright or any of the other faculty have any other thoughts about fixation techniques? Or if not, we can kind of jump back to Marco if he's still there. And I think he just got out. So I think one of the things that I wanted to jump to next was sort of tips and tricks, kind of pearls, things to avoid while picking your femoral tunnel site and your tibial tunnel site. So, when you're putting your guide on, and this is going to be hopefully just a broad application for us trainees, residents, registrars. What are some things that you relied on early in your career that really helped make you feel secure that you had your tunnel position correct? And if you could just give us a quick summary, maybe your thoughts on that. And then we'll jump to Matthew, who's one of our medical students involved in the Bone Club, who looks like has a question for us on stage.
Perhaps I could. In terms of tips or tricks, I suppose the main issue, it's nice to hear that a lot of the people on the panel are using anteromedial portal for their femoral tunnel. I agree that using a jig through the lateral portal and then a flip cutter can give an excellent position. I don't think either anteromedial or a flip cutter from the lateral side, there's a significant difference. As long as the surgeon is sure of their anatomy and their landmarks. When we started out, we were using a transtibial for the femoral tunnel, and what was patently clear was that your femoral tunnel position was then solely reliant on your quality of the angle of your tibial tunnel, and using the old offset guide jigs to put a guide wire certain distance in front of over the top of this position, it tended to work. You could get into difficulties as soon as your tibial tunnel was in the wrong place slightly. The problem just was magnified when you got to the femoral side. By swapping over to the anteromedial portal, personally, I felt I can be sure of the anatomy. I think we've all moved away from the idea of a clock face, which is a two-dimensional representation of where the graph goes. And a lot of people are happier to look for the bony anatomy on the femoral side, on the medial side of the lateral femoral condyle. You want to be able to see what we call the registrar's ridge, or although I suppose in America it's the residence ridge, and ensure your graph position behind that. And you can look at the eminence, which is the anatomical landmark between the AM and PL bundles. I suppose whenever we're talking about ACLs, we have to throw into the equation if anybody still considers doing a double bundle. Personally, I don't. I use a single bundle technique. But for me, it's important to see the true anatomy on the two sides of the joint, and try and for a single bundle, try and pick a tibial entry point which is in the center of the footprint. And I try to look for both the AM and PL entry sites, and then the same thing on the femoral side. So I'm drilling through the medial portal in deep flexion. It's not an accessory portal. It's just a slightly more medial and slightly more inferior portal than you would usually use for just a standard diagnostic arthroscopy. And with deep flexion, you make sure that you avoid scuffing the medial femoral condyle as you insert your drill. In my hands, I find that works really well. The important points, especially with the suspensory fixation techniques, is to make sure that you take your button outside the femur. You're sure it's outside the femur, but not outside the soft tissues. So a good point to note is that you've seen the occasional X-ray where a suspensory button is sitting probably outside the ITB rather than on the femoral condyle. intraoperatively, you may not think it's an obvious thing that can be done, but it's believe you me, I've seen it. The nice clinical tip is that when you're cycling the graft intraoperatively, you'll see a dimple on the skin on the lateral side of the femur as you're cycling the knee. Now, that makes you sure that your button is in the wrong place. So we want to make sure that the button is sitting nicely on the cortical bone on the femoral side. I like to have the graft filling the whole of that femoral tunnel. We want to avoid the bungee effect on these buttons, these suspensory fixation techniques. So making sure that you fill the graft all the way up to the top of your tunnel. It's a nice trick to also take the scope through the medial side. As you're taking your graft up through the knee, you can put your scope through the medial portal and you can look straight up the femoral tunnel and see that the button is outside of the femur. You can ensure that it's in the right place, and then you can watch the graft going up into the tunnel through that medial portal as you're toggling the graft up using the tightrope, which I see a lot of surgeons in the panel have been using. Thanks.
Yeah, well, Mr. Merrill, that was a perfect summary. Sounded just like one of my attending faculty members walking me through an ACL. Those are really a lot of the key points and the highlights that residents can think about. I just wanted to do a quick reset of the room, and then I'm actually going to let Marco jump in here. Just for everyone here, this is the Bone Club. We're doing our ACL Reconstruction Journal Club. Thank you all for being here. We're going to try to wrap ourselves up somewhere around 75 minutes, but for those who want to stick around after and just chat a little bit more, we're going to keep the room open for anyone to talk all things ACL. We've been talking about graft choices, fixation techniques. Seems to be a medial portal technique is popular. Hamstrings obviously more popular in the UK, and it seems like we've had a couple of surgeons talking about using quad and BTB more extensively here in the US. And then we've talked about fixation techniques, and it seems like some people are using the flip cutter, doing an all-inside technique. Others are using interference screw fixation, but obviously all that depends on graft choice. Akib, I don't know if you look like you wanted to jump in, but if you don't have anything to say, I'm going to let Marco kind of give us his 2 cents about grafts again.
Hey, everybody. Hopefully third time's the charm in this one. Real quick, just before I accidentally even get cut off. Bottom line, like I was mentioning, when you're working with athletes in the professional setting or any type of collegiate setting and participating in any type of explosive plyometric sports, as we all know, the hamstring is a key stabilizer from having the tibia shift. So we've seen a lot of higher rate of return to sport with athletes when they've had more of a BTP compared to a hamstring. I think there's a study out there that kind of has shown here in the US. One of the biggest issues is that as far as prehabbing them prior to the surgery or even after the surgery, we can go and start working on the hamstring muscle right away and strengthening to try to kind of stabilize the tibia as we're returning to play. So bottom line, though, I've had a better success with athletes with more of a BTP compared to hamstring, but at the same time, like Dr. Neiman said, it also varies on the surgeon. Those are just my 2 cents, and I'll probably stop here. My name is Marco. I'm done speaking before my phone cuts off here.
Thanks a lot, Marco. I'm glad we got your 2 cents in there. Akib, you got something to jump in on?
No, I was just congratulating Simon on giving such a good review of his technique. I'm really curious to hear from members of the panel. So in terms of what I've experienced as a trainee, I've seen a lot of hamstring tendon grafts from multiple trainers, and I worked with Henry Burke in Wexham, and he does a hamstring tendon technique. I don't know if you want to go over your technique with the panel.
That would be great. Yeah,
sure. Thanks, Akib. I'll keep this really short because I know we're tight for time. But the nice thing you just did, Denor, was the tips and tricks things for people listening and people learning. And this is great that this is free education for people. And Simon gave a very nice summary of his tips. My best tip that I can give all people learning, and Akib will know because he worked for me, is try to get the setup right at the beginning, because if you are looking for a standardized femoral tunnel, and the femoral tunnel could take up a whole hour and a half of our discussion. If you're trying to get it right, the best thing you can do is watch what your boss does in your final residency job or your final registrar job. Take some photographs of what the boss does, because the way that the leg is on the table, the side support, the tourniquet, the position of the leg, the position of the camera, the position of the light source, the position of the portal then comes, and then the position of your hand when you drill the femoral tunnel through the anteromedial portal will all come together in time. But if you skip those steps and you're interested in where the anatomy of the femoral tunnel is, then I think that you will miss that important bit of the setup. So set up. As I say, take photographs, take a video of what your boss does. I think that will really, really help you all going forward.
I just want to, I was applauding while you were saying that, because as I've had the privilege of teaching my entire career, and as I teach the fellows and the chief residents, often the urge is to get your hands on the instruments. But I could not applaud you more for what you just said, that as a trainee, please watch what we're doing and why. Because sometimes you think that where the leg goes and where the post goes and where the portal goes is accessory, but I applaud you for pointing out that those are the critical details that sometimes, if you're accessory, but that's why attendings watch other attendings at meetings do surgeries. It's not because they need to put their hands on the instruments to learn how to triangulate. It's to notice the nuances of the elegance of the surgical technique down to where the leg is. So I love that you said that, and I just wanted to augment that for all the trainees listening. Just watch the details because everything matters.
Can I also add, Harun Aboka here, that I brought it too because I think when we're all training, we're just interested in the actual technique, but the preoperative setup, the position of the tourniquet, the side support, the degree of flexion of the knee, depending on what approach you use, those are really instrumental, purely because even when you're teaching non-ACL surgery, it's that what is what the trainee, if they do not notice this, they run into trouble. And of course, there's nothing worse than seeing a trainee in the coffee room depressed because they feel that they've done something that has taken a lot longer than they would anticipate because they compare themselves with a boss who might have been operating on the same type of procedure for a number of years. Can I also add very briefly that Simon's synopsis was tremendous. The other thing I'd like to add is that the landmarks for the tibia will be important because once you, when your drill pin tip, good idea to just extend the knee to make sure that the drill pin is not going to be impinging against the notch, which would be a problem with graft positioning and potential graft failure. Thank you.
Yeah, can I just echo that? The tibial position is just as important as the femoral position, and I think certainly early in my career, I got the tibial position a mil or two not quite right, and either you need to maybe debride the graft a little bit more sometimes to get the tibial position right. In my pediatric patients, I actually drill it under image intensifier because you have much less room for maneuver. Just a couple of other things I'd add. Setup, absolutely. The other thing I've seen when I've taken trainees through, particularly the femoral tunnel position, is if their camera angle is not right, if the camera lead is off center, so it's rotated, the whole picture is rotated, they get their tunnel position completely wrong. And it's not because they've got their anatomy wrong, they've actually got the camera orientated wrong. And the final
I think we've just lost you there. Do you want to just repeat? Yeah,
yes, we can hear you. Thanks.
Yeah, sorry. The final thing was, please prep the foot. I don't understand why you don't prep. In a case that's got a huge amount of water, swim. I cannot understand why people don't prep the foot for either an ACL or a total knee replacement. I think it's actually negligent. It's the second dirtiest part of the body.
That's a great point. Something probably all the residents need to be aware. Dr. Wright, you had something to say? Go ahead.
I didn't know that people didn't prep the foot, but I completely agree. In fact, I make a boot around the foot. The HSS boot, it's called. We seal off the whole dirty foot with an extra set of IOBAND for exactly that reason. There's water down in there. You just don't want to contaminate your knee going up and down with your cycling. Please seal off your dirty foot.
Absolutely. I'm going to let Matthew, actually, I'm going to let him introduce himself, but he's just to give you some background. He's been coming to some of our events for the Bone Club, and he's a medical student, so I think it's going to be really nice to have a different perspective up here on stage. So, Matt, why don't you jump in and just give a brief introduction and ask your question if you have one, or just wanted to say hello.
Yeah, I do have a question. Thanks for having me on stage. Like Dr. Damodar said, I'm second year medical student at University of Cincinnati, pursuing orthopedics. Even as a student, I've heard of like the rising popularity of the quad tendon repair. As I understand it, the advantage to patellar bone is fixation because of the bone plug. And so I was hoping you could speak on why you would or would not use a bone plug in the quad tendon, because like I heard Dr. Nima say he mostly does soft tissue, and so I was wondering, why wouldn't you use a bone plug?
Just wanted to jump in and say, great question. Well above your level of training there. That's awesome. Go ahead, guys. Anyone?
Thank you.
Well, I can tell you, even though I said the caveat that I don't do a lot of when the NIH R01 grant was being done, that despite meticulous technique, there was an incidence of patella fracture when they took the bone plug out of the proximal pole of the patella. And subsequently, people found that the soft tissue grafts were great. So as you've heard today, so that house of sports, the bone plugs went out of fashion.
And can I just ask a follow-up question? Would you not see patellar fracture with patellar tendon autograft with bone plug then?
Knock on wood. I personally have never had one. Can you have them? Yes, but it has to do with technique of taking the graft. So you know how in the OR conversations are going on, and they may or may not have to do with what's happening in the moment, just because there are some parts of the case that you can be talking about something else. In my room, when I am taking the patellar graft, we're not talking about anything except my hands taking the bone plug out of the patella, because the patella is only about 2 centimeters thick, including the cartilage. And if we're going to take a 1 by 1 by 2.5 centimeter bone plug, we can't plunge the saw, right? You have to know how deep it is. I do it by hand. I don't use a stop on my saw. So I am concentrating on the depth of my saw. I'm concentrating on the angle of my saw. If I am concentrating on overcutting the corners so that when I put my 1/4-inch curved osteotome in the top of my graft, I can barely tap it and the bone plug will come out. I always say this out loud in front of my trainees. If you have to torque on that curved osteotome at all, stop and recut the corners, because what you'll do is you'll increase your likelihood of breaking your patella, or even worse, you will pop out the cartilage. You will go so deep that you'll pull the bone and the cartilage out, and then you've got a big hole, right? So you never want to violate the subchondral bone and the cartilage. So you have to concentrate so deeply during that portion. And maybe it's just me. Maybe other surgeons in the room are better at it than me. But when I'm cutting that, even almost 20 years later, I am deadly focused. That's why I think that I have not seen a lot of patella fractures with the inferior pole bone plug.
I think that's an awesome point. Mr. Burke, we'll get you in here really quickly. I just wanted to let everyone know again, we're going to be probably wrapping up in the next 5 to 10 minutes. If you guys can come to our website, actually, you can find via Clubhouse on the Bone Club. There's going to be a podcast live later tonight, so you can share with your colleagues and get more people involved and interested. But really well taken, Dr. Wright. Mr. Bork, you want to jump in and let us know your thoughts on patella fractures and BTB or quad?
I liked Matthew's question, which is why I wanted to answer it in a slightly different way. It's great, Matthew, you're thinking about this, because this is exactly what you need to be doing at your stage. Now, there is a significant difference between healing of the graft between bone to bone and soft tissue to bone. And I was really surprised when I went to visit Don Shelbourne in Indianapolis, who, as you probably know, is a big patella tendon user and has been for many years. His patients are back on the basketball court after about 12 weeks. They're not playing, they're training, but he says it's all healed by then, so there's no problem. And with hamstrings, you have to go much slower than that, because you've got the graft has got to incorporate against the bone. So soft tissue healing to bone is different of bone to bone. So when you're using a bone, you've got to think about what you're using it for. And the answer to your question in my hands, I don't do any primary quads yet, but in revision cases, it's useful to put the quad tendon graft upside down and fill some of the bony defect with the bone. So it depends on the use, is in answer to your question, and it depends on the healing, and you've got to think about the healing before you rehab that patient.
Yeah, really excellent point. Well taken. Thanks, Mr. Bork. Anyone else want to jump in? If not, we can probably just open up to one or two last final comments, and then maybe wrap up our discussion for the day. Once again, just want to thank all the panelists for joining us. For those of you in the audience, if you can please follow the panelists. Obviously, they all have excellent information and wealth of knowledge. Be able to catch them in other rooms on Clubhouse in the future. So I think with that, it seems like we've had a pretty robust discussion about ACL reconstruction today. We look forward to seeing you at the future events for the Bone Club. Akib, I don't know if you want to jump in with any last minute housekeeping or thoughts, but if not, I think we can wrap up.
I want to congratulate you. That was a one, well moderated, and thank you all the panelists for joining us for this discussion. It's our fifth time doing the Journal Club. It's growing every week. The podcast is growing for people who can't make it because Sundays can sometimes be a bit difficult. So the knowledge you shared will be widely spread. And please do encourage any trainees or anyone else, colleagues that may be interested in the platform to join us and become involved in the Bone Club. It belongs to everyone. We're here to collaborate and get, cross-country, cross-nations, cross-border collaboration going so we can spread orthopedic knowledge and help our patients. So thanks, everyone. And back to you.
Yeah, thank you all. Unless someone has a last-minute comment, we can all sort of slowly head out of the room.